has been our long-serving director. Actually, what's your title? CEO of the UMA. Those who are part of the UMA, raise your hand. It really should be all of you. If you haven't raised your hand, repent and join the UMA. So Michelle, we'll turn the time over to you for an update. Oh, I do have one other announcement. Somebody lost their rental car, Malibu fob, and Teresa has that at the front desk. There will be a fine for you to be able to obtain it, and it will be very expensive. So, Michelle, you're on.
Green button forward. Advanced slides, green button. Thank you. Good afternoon. It's good to see all of you. Let me just kind of put my papers in order here. My name is Michelle McOmber. I'm the CEO of the Utah Medical Association, and I am here to present on the Utah legislative session that just ended in March of this year. I'm not presenting on federal, so just state legislation at this point in time. It would be too long to try to do federal too. I'm not sure where I'm supposed to, okay, there we go. So just a little bit of general information before we get started into the legislative session and the bills. There are, because this makes a difference in kind of the decisions that legislators make in the state on legislation. There are 6 Democrats out of 29 senators in the state of Utah. There are 14 Democrats out of 75 in the House. So that tells you, and then we have a Republican governor. So we are a super majority Republican state. So keep that in mind in terms of when we start talking about legislation and different decisions made by the legislature on health care. There were about 1,000 bills and resolutions that were introduced this year in our session, in our 45-day session. 976 were numbered, 591 were passed, so that's another record-breaking year for us in passing bills in a 45-day session. We had about, around 185 bills that dealt specifically with healthcare, and then there were other pieces and other pieces of legislation that had a little piece of healthcare in them. So we look at many, many bills each year as we look at healthcare in Utah and what's happening at the legislative session. You know, watching legislation happen is a little bit like, as the saying goes, watching sausage being made. And that's not something that's very pleasant. It isn't very pleasant to watch legislation in the state of Utah many times. We do, although for doctors, I'm sure you see a lot of unpleasant things, so maybe it's not so bad for all of you. But some of the decisions that were made in the legislature, I'm sure you feel that same way. We right now are in the middle of a legislative session, or an interim session. In fact, they're meeting today. They met yesterday. They'll meet tomorrow for a few sessions, a few different committee meetings, and we continue to meet throughout the summer, and then we have our full session starting in January. And during interim session, bills are considered and become committee bills also. So it is a year-round process in terms of looking at bills that come before the legislature, and we often have also special sessions, and I won't go into that. But so I'll jump right into the bills that we have. I'm just going to go through different categories of bills, and I'm only presenting a small portion of the bills, but ones that have effect on healthcare and you as healthcare providers in the state of Utah. Okay, so in behavioral health, we have a behavioral health access problem in Utah. We do have a lot of bills that are brought forward in behavioral health, how to expand access, what to do with behavioral health, how to provide enough services, etc. So House Bill 71 provides grants for the development of more mobile crisis outreach teams in rural Utah. This one actually is something that we as a medical association have supported because it is a point for access for patients who are in crises. And also this allows it to happen in rural areas. So we know this is a particular part of expansion of behavioral health that has worked in the state of Utah. Senate Bill 27, Behavioral Health System Amendments by Senator Evan Vickers, is actually codifying the Behavioral Health Master Plan that was developed by the Huntsman Mental Health Institute, Kempsey Gardner Institute, and also with experts in the field of behavioral health, a lot of physicians and others who work in behavioral health. So this particular bill is also one that we supported. It expands access to behavioral health in Utah and puts a plan in place on what's going to happen to behavioral health in the future and how we're going to cover the needs of Utahns. So this one also passed. Other behavioral health bills, Senate Bill 26, which was run by Senator Kirk Bramble. By the way, he always runs scope bills. He always runs bills that many times we have a lot of problems with when it comes to healthcare bills that he runs. This particular bill is a huge omnibus bill that drastically changes behavioral health in Utah in terms of adding particular training certification and for different levels of providers that we haven't seen before in behavioral health, some of them good, some of them we'll see. So it created mid-level providers of Master Addiction Counselor, Associate Master Addiction Counselor, Behavioral Health Coach, Certified Behavioral Health Technician, and others. It did decrease hours for some of the supervision requirements for mental health therapists. It also reduced some of the hours to even just get the training and created alternative pathways for some of these mental health therapists to not have to take tests to pass and to become therapists. And so it did change a lot of things. It also is combining the mental health therapist board. So we're talking about social workers, we're talking about marriage and family therapists, psychologists, all of them on one board within DOPL. And then also given extra duties to look at the behavioral health system in Utah and how to reform it. Now, this is through DOPL. The reason that's a little bit concerning to us is that that's not a role for DOPL, has never been a role for DOPL. DOPL has been the licensing division in Utah. You all know you have to get licensed through DOPL. But now it's saying these boards are going to make recommendations of what should happen in healthcare. So other commissions and boards that were out there that had dealt with these issues, that had experts on them from all different fields, they won't necessarily be doing this anymore. It will become through DOPL and through the Division of Commerce. So that's a concern. Psychologists did receive a certain amount of ability to prescribe in this particular bill. The Department of Commerce recommended that they just be able to prescribe. We put different things within this bill to pull some of that back, so they are able to do SSRIs if they get a master's in clinical psychopharmacology, and if they take certain courses, if they are under the supervision of a primary care provider or a physician, and if they have a certain number of hours, 4,000 hours doing that. Controlled substance bills, just want to mention a couple of controlled substance bills because this does affect you and information that you have or the drugs that you prescribe. So House Bill 131 enables pharmacists to substitute and pharmacy interns to substitute prescribed drugs with therapeutically similar alternatives under specific conditions. So the conditions are that the boards of DOPL, so the physician licensing boards and pharmacy board get together and they come up with a list of drugs that are therapeutically similar. And once they come up with this list, only those drugs on the list can be substituted. And they can only be substituted if you as a prescribing practitioner actually say on your prescription pad or prescription form that it can be substituted. So it is driven by the prescriber in saying whether or not it can be done. Also, they have to not have the drug available that you originally prescribed within the pharmacy. So sometimes that happens when a patient goes into the pharmacy, right, that the drug may not be available. And then also it can't be more costly than the drug that was prescribed. So there are certain requirements in place for that. House Bill 260 is just simply adds gabapentin to the Schedule 5 of the controlled substances list. So now it's a scheduled drug where before it was not. This was a recommendation of the Controlled Substance Committee that is in Utah that meets to look at these kind of drugs. Like last year they did some stuff with tramadol, etc. Other controlled substance bills that passed, Representative Ray Ward, who's a physician also, he sponsored this bill that says that you can, so an administrator or somebody from a methadone clinic needs to give information to the controlled substance database. So part of the problem that we've had with the controlled substance database is that people that are on methadone doesn't show up in the controlled substance database when you look at it. So this is methadone or any other controlled substance that a patient is on for the treatment of substance use disorder treatment. So any of those clinics that provide those kind of services for a patient. It's important, of course, as you all know, if you're going to prescribe an opioid, to know, hey, these guys are on methadone for helping them with a substance use disorder. So this will take effect, it actually has taken effect May 1st. So this will be something that will have to be reported to the controlled substance database. So the next time you look at patients, you should have this information also. It also, if there are some issues that on prescribing that Doppel flags, say with opioids, it expands the ability for them to provide education to the prescriber that has been, that is maybe out of what they consider a norm in prescribing. Senate Bill 61, electronic cigarette amendment. Senator Jen Plum, who's also a physician, ED doc, pediatrics. We've been working a long time to kind of rein in a little bit of the excesses of e-cigarettes in terms of, one, nicotine content. So this started out including limiting nicotine content. A couple of years ago, we passed a rule through Department of Health to only allow 3% nicotine content in e-cigarettes. Juul sued the state backed off, and now it's 5%. So this bill would have brought it back down to 3%, but in the end, Senator Plum decided that it was better to get rid of flavors than to worry about the nicotine content, since we already have a restriction to 5% nicotine per milliliter, milligrams per milliliter of nicotine. So this prohibits the sale of flavored electronic cigarettes products except for menthol, and they cannot sell anything in the state of Utah that is not FDA approved. So this is a huge deal for electronic cigarettes in Utah. We've seen a drastic increase with teens and kids in Utah using these e-cigarettes, and so getting rid of bubble gum and candy cane and all those other flavors that appeal to children will help us with keep this under control a little bit better. Death certificate amendments. This is again Dr. Ray Ward. He passed this bill and sponsored this bill that would allow you as a provider who is able to fill out death certificates, so only those who can do so, to say that you don't know the exact cause of death. So if somebody comes to you or a year later and says, hey, I want you to fill out this death certificate for your patient, and you say, I haven't seen them in a year, I don't know what their exact cause of death was. You can put down the underlying condition if you want to say, I'm not sure what the exact cause of death was, but I was treating this patient for whatever, a heart condition. So it also modifies the deadline that you have to submit the information. You have to do it within 3 days. That's more for the side of the individual being able to be buried and the funeral directors being able to collect the body and get that patient or that person buried. And DHHS, Department of Health and Human Service, will provide instructions related to this. House Bill 200, Order of Life-Sustaining Treatment. This will be important to some of you, not to all of you, but it modifies the standards for physicians, APRNs, and PAs related to do not resuscitate for children. So you have to have a parental consent for do not resuscitate for a child. And that's basically what this changes this to. There are some other specifics in the bill, but that's the underlying piece of this bill. House Bill 224, medical surgery amendments. Representative Marsha Judkins, we all know there was a transgender minor surgery bill last year. Representative Marsha Judkins wanted to rein in any surgery having to do with any kind of sex characteristic changes in a minor. So that would be an example. One of the things she was specifically targeting was breast enhancements of minors, so a 17-year-old. And so she wanted to rein that in. The problem with the bill was that it was very broad. The bill said sex characteristic changes. It didn't say if it was medically necessary, you could still do it or anything else. So we had problems with this bill. We were able to add medically necessary, but then also the bill was defeated. So House Bill 193, hospital assessment revisions, again by Dr. Ray Ward. This one actually extends the funding for some of the Medicaid services that we have in the state of Utah. The hospitals have an assessment that helps bring down a federal match that allows some of those funds to go to the state of Utah to help pay for some of the Medicaid expansion services and Medicaid services, healthcare services that we have in Utah. So this would have, it would have sunsetted. It would have no longer been there if this bill hadn't passed. So again, this funding source continues for another, I think it was 10 years that it was passed for. House Bill 267, telemedicine amendments. You know, a number of years, we and others have tried to get the telemedicine amendments passed to get equal parity of pay for doing telemedicine services for patients. And of course, we're always fighting the insurance companies. On this one, there were some games played behind the scenes on this particular one this time, and it was transferred to another sponsor to run the bill and everything else. But it would have actually required insurers to pay 90% of in-person rates to a provider for doing telemedicine services. It couldn't be an expansion of services, so it's only what's allowed to be done through telemedicine. It couldn't. It wouldn't have allowed them to do an inappropriate care with telemedicine, and it wouldn't change the contract that a provider has with an insurance company. It would just say, you've contracted for this amount for regular services, healthcare services, now pay 90% of that for telehealth services that the provider sees the patient. And that one did not pass. House Bill 387. So we have physician workforce shortage, as we know, in Utah. We have medical schools and more medical schools now. We don't have more residency funding or training programs in the state of Utah. We have a few more that we were able to pass last year and the year before. But there are two things with this. So this particular bill allows grants that were put in place in 2023 to continue to allow for residency grants to renew residency programs. However, the Executive Appropriations Committee of the legislature, so they're the ones who decide what the total funding is for the state in all areas, including in healthcare, cut residency funding in the state of Utah by 25%, and that would have been across all programs. At the last minute, we and University of Utah were able to get into the overall funding bill the ability to do what's called intergovernmental transfers, and so University of Utah is held whole for their residency programs. They're fine. They'll probably get actually more money through the intergovernmental transfers, but programs like Intermountain Healthcare residency program was cut 25%, and some of the other smaller residency programs. So that's something we're going to be working on this year, is to make sure that funding for residencies is appropriate and actually increased. We just had increased it a year or two ago, and now all of a sudden there's a cut. And that's what happens every year. You have to go up there and fight for funding. House Bill 463, Medicaid funding amendments, Representative Brady Brammer. I wanted to mention this one because it's back. It's being heard in interim committee meetings today, but it did fail. There were a lot of groups, including the Medical Association, working against this bill because what it would have done is said if there's a Medicaid shortfall, and it defined a Medicaid shortfall, saying if we got less money from the federal government for our programs, because we get a match, we have a state portion we pay and then we get a federal match. If we got less money by 0.5 percentage point up to 3 percentage points in any given year, automatically that would be a shortfall in the Medicaid budget. And if that happened, it put in place automatic cuts to the Medicaid program. One of the cuts would be any provider increases that were implemented in the year that the federal cut happened, and services, anybody new getting onto the Medicaid program, and all sorts of different things. Optional services would go away altogether. So this was a bill that was very concerning to us. We fought against it, as did others. There is a process already in place in the legislature. It goes before the Social Services Appropriations Committee to say, okay, we have this much money to spend for health care. How are we going to prioritize it as a committee? And that's a legislative committee. And so every year they go through that process and they say, okay, here's the prioritization, and then they give that bucket of money and the recommendations to executive appropriations, who funds or doesn't funds what is recommended. So there is a process to do this already, to say, hey, we think we're going to see a shortfall this year, and we and others argued that this should continue to be the process because we already have a process in place to take care of these things. So this bill failed, but it's coming back again. Representative Brady Brammer is bringing it back. And oftentimes we will see bills like this come back and back and back. This one, international licensing amendments, this was concerning to almost all licenses. And I'm not just talking about healthcare. I'm talking about architects and engineers and everybody out there to sit, because it says that if you are a foreign trained graduate and you want to come to Utah, if a certain committee, right now they're saying DOPL committees, said that your education and training was similar, not the same, similar, you could automatically be licensed in the state of Utah. Okay, problem with that, and I'll just speak from the physician standpoint, although I know the nurses were up in arms about this and everything else too, is that we have a system that foreign trade graduates can go through to become licensed in Utah. But we don't, and we have an ability on a federal level to determine if they have the same medical school training. We do not have the ability to determine if their residency programs were the same. With some countries we know, England, some of those. Some countries we have no idea whatsoever. So if you have a group and they, DOPL, the Department of Commerce, met, and we actually had the nurses call us and say, hey, can you get on this call with us, because they're going to try to say that any foreign trained physician can come in and be a nurse without any extra education or anything else. Well, the training programs are different. They're not the same. So to say that physicians could just come in and be a nurse, that was concern to us. So this is we managed to get an amendment in this particular bill that says that the people that are going to look at it are not only the DOPL boards, but those who put the training programs in place for the profession, so they can look at it and determine if it is similar or the same. But the problem with that too is that we then become a silo in Utah where this can happen, but it's not a portable license. So there's a lot of problems with this bill, and we still have concerns with this bill. We will try to work forward as we go forward and see what happens with it. House Bill 560, licensing modifications, Representative Carrie Ann Lisenby. So last year when the big restriction on abortions went into play, or was passed, they also did away with abortion clinics. We had 3 in the state of Utah, abortion clinics. So they did away with those and said that all abortions need to be done in a hospital. The issue with this, of course, and the physicians were, OBGYNs were not happy with this, is that it's more expensive in a hospital. And so even though the restrictions on abortion was put into place, it still said you could not do an abortion any place but in a hospital. So the restrictions on the abortion are you can do it for the life and health of the mother. That was passed in the state. You can do it if the if the fetus is non-viable, you can do it, and there's restrictions in there about who has to say that there's non-viability in the life and health of the mother. It's 2 maternal fetal medicine doctors agree. You can do it for rape or incest, and you can do it up until 18 weeks for rape or incest. You can do it whenever necessary on the case of the life and health of the mother or the fetus is non-viable. But the problem, again, is even for rape and incest, they said, nope, you've got to go to the hospital to have this done. So we have a lawsuit against the state of Utah on the abortion bill that passed. Actually, before this, the trigger law that passed, and it's still in the courts. And so because of that, Representative Carrie Ann Lisenby, who ran the abortion bill last year, came back with a modification to the bill allowing licensing of abortion clinics to do legal abortions in the state of Utah, which is not what is considered elective abortions. And I'm not going to go into the definition of that. That's just the vernacular, of course, at the legislature. So legal abortions are life and health of the mother, fetus is non-viable, rape and incest. So it can be done in certain clinics under certain requirements. They have to be, by the Department of Health, has to certify that they have the same standards and requirements as in a hospital in terms of safety and some of the other things. Vaccines, so we still are always up at the legislature seeing vaccine bills come every single year. This year we had 2 different vaccine bills. One was a disclosure bill from Representative Trevor Lee that would have said, okay, if you are getting extra payments rather than just for administration of vaccines, you have to disclose. Well, we asked physicians, are you getting extra payments in any way? They're like, no, we're not getting extra payments. We ask insurance companies in Utah, are you paying extra for vaccines? No, we're not paying extra for vaccines. Now, I mean, there's overall bundled, if you're doing well care for your patient types of things, but nothing you could break down. So this was a concern to us. We fought against this bill. This bill failed. HB 405 public health amendments, which was known as the med student vaccine amendments originally, would have required would have said medical students, you cannot require a medical student under any circumstance to have a vaccine. Not just a COVID vaccine, by the way, any vaccine. And so this was concern to us, and also those who train medical students to say, wait. So the amendments that were put in that bill that we were able to get into the bill were that any vaccination or face covering mandates that the hospital has for a regular healthcare provider can be also held for the medical students. Now, remember, we still have a way for a medical student or anybody else to receive an exemption for not having a vaccine, but they have to go through the process. And medical students have this same rights provided under Title VII of the Civil Rights Act. And as long as those are met, then medical students, again, can, if they don't feel like having a vaccine, they can go through the process, and they may or may not be given exemption from having a vaccine. I'm just going to move on to other types of healthcare bills that were passed this year that were looked at. Senate Bill 166, Health Benefit Amendment. Senator Michael Kennedy, who is also a physician and also an attorney, who, by the way, is now running for John Curtis's seat for Congress. He ran this bill that says that if a health benefit plan requires a patient to change their prescribed long-term drug that they've been on, the healthcare insurance provider must provide 30 days notice, and they must give justification in writing why that has to happen. Now, there are some exceptions. If it's not on the formula and has never been on the formulary, that's an exception. And then also, if this one I couldn't remember, so I pulled it up. If there's another drug, if there is a biosimilar long-term drug that is the same, basically they can say that you need to try that one. Placental tissue amendment, Senator Curtis Bramble. Remember Senator Curtis Bramble? I told you he runs the healthcare bills that mostly concern us. This one, not as concerning, but still an extra step, an extra administrative burden that has to happen. Requires healthcare providers to provide patient with written notice. This specific written notice has to have exactly these words before performing a stem cell procedure, regardless of what the stem cell procedure is. This notice must be provided to you under Utah law. This healthcare practitioner performs, so it could be up on the wall, by the way, performs one or more stem cell therapies that have not yet been approved by the United States Food and Drug Administration. You are encouraged to consult, and that has to be spelled out, by the way, FDA. I did the abbreviation, but it has to be spelled out, Food and Drug Administration. You are encouraged to consult with your primary care provider before undergoing a stem cell therapy. There's a little bit more to that particular bill. A consent has to be signed by the patient, or if the patient is legal to say, well, if the patient is legally competent, not competent, then the patient's representative. The language has to say that, or the patient has to be able to reasonably be expected to understand from the consent the nature and characteristic or character of the proposed treatment, including the treatment's United States Food and Drug Administration approval status, the anticipated results of the proposed treatment, the recognized possible alternative forms of treatment, and the recognized serious possible risks, complications, and anticipated benefits involved in the treatment and in the recognized possible alternative forms of treatment, including non-treatment. So this one also is a little bit complicated. Anybody who has does stem cell treatments needs to be very familiar with this particular bill that passed, the law that passed. HB 261, Equal Opportunity Amendments, initiatives by Representative Katie Hall. There's been some pushback up at the legislature about all of the DEI things that have been going in place, so diversity, equity, inclusion, things that have been happening across the country, in the state of Utah and elsewhere. And there were particularly people who are upset about, legislators who are upset about the fact that in healthcare they think that this is going overboard for DEI, for saying, and this is, I'll quote one legislator, I won't tell you who it is, that, you know, the white male who is in Utah can't get into a healthcare program anymore, a healthcare provider program anymore because they're discriminated against. So these are some of the sentiments that were behind this particular bill. Now, there were a lot of people on both sides of this bill up at the Capitol, a lot of people. Some you wouldn't have expected to be on either side of the issue, or you would have expected to be on one side of the issue or on the other side of the issue. This particular bill, we did try to get an amendment in. We were told this was a governor bill, a leadership bill. It was going to go through how it was. They were not accepting amendments. Because we were a little bit concerned about how would this affect medical schools and residency programs and what is happening and the schools making a determination of these types of things. So again, we were also told, though, by educators, including some at the very institutions we were concerned about, who said, we don't think this is an issue for us, and so we're okay with it. So this particular bill did pass, again, leadership bill, and it was going to pass no matter what. So any leadership bill, that is the case. The leadership can push a bill through without any amendments whatsoever. Other bills continued. Medical malpractice pre-litigation panels. And by the way, I just got a text earlier as I was sitting down here about pre-litigation panels that they're discussing it today up at the Capitol. I'm not there, but they're not going to vote on it, so it's okay. During interim session last year, that's in between the general session, there was a proposal to do away with pre-litigation panels, and we had a real problem with that, because one of the things about pre-litigation panels is you go through that and there's a finding of that it's non-meritorious for them to go forward. An attorney could continue to push a lawsuit, so it doesn't absolutely stop it, but the reality is probably they aren't going to, because they saw what the documentation was on both sides for or against a case. So push to get rid of pre-litigation panels. We actually stopped it in interim committee last year, but again, like I said about some bills, they just keep coming back. So I got a text from one of the legislators who said, hey, did you know that they snuck this issue into the agenda today? And so they told us we have two choices as legislators: get rid of them, or we can have data collected. But either way, there was going to be a bill on this particular issue. So this is coming back. We defeated it in October of last year. Here it is only May, and it's back again. Child custody proceeding amendments. So this one is, I don't know if any of you are aware of Caden's Law, but this particular bill, by the way, was a resolution in the UMA House of Delegates last year. And so this law establishes comprehensive guidelines for child custody and parent time proceedings, mandates courts to consider evidence of domestic violence, abuse, and other factors impacting a child's safety and well-being. This was particularly important to our pediatricians, of course. Outlines procedures for supervised parent time, expert evidence, admission, and emphasizes the prioritization of the child's safety and psychological health when in custody decisions before the court. So this bill did pass, and we were very supportive of this bill to protect the children. House Bill 570, healthcare facility amendments. So this one failed. It ran out of time, and there was huge pushback from some of the systems that have freestanding EDs in some of the areas of the state. So Representative Katie Hall, who, by the way, is married to an orthopedic surgeon in the north, ran this bill on behalf of ED physicians to say it would have established, and she's a nurse too, so she sees this firsthand, this stuff happening where they don't feel like in some of these freestanding EDs that there's enough personnel to do what needs to be done in an emergency department. So it would have established minimum standards for freestanding EDs, and specifically you can read there, but CT scans, ultrasounds, x-rays, clinical laboratory tests, because it's important to be able to get those tests very quickly, along with a licensed physician specializing in emergency medical services being in that freestanding ED, and then some other individuals. So huge, so we already started meeting again on this bill because it will be brought back in 2025. We met last week on this bill. We met with all of the systems about this bill, and she's passionate about this. She's heard from the healthcare providers, not just physicians, but again, her colleague nurses and other healthcare providers in these areas who are saying, look, we don't feel safe, that it's safe for patients. We don't feel that we're being able to give them the kind of care that we need to give them in these freestanding EDs. And if they are known as an emergency department, even if they're freestanding and they are attached to some system or hospital, but not close necessarily, then there ought to be a certain standard that is met before it can be called an ED, as opposed to an urgent care or an Instacare, right? Something like that. So this bill is coming back. There's discussions happening about this, and we'll see what happens with this bill this coming year. Another bill, which is a prior authorization bill by Senator Jen Plum. I forgot to put MD on the end of that. She's the ED pediatric physician that I mentioned before. She ran the e-cigarette bill. This would have mandated that managed care organizations have to respond within certain time frames for various types of medical care that are needed mainly in EDs, but also in hospital situations where a quick turnaround and answer is needed. We had passed a prior authorization bill that reformed prior authorization 3 years ago. The big pushback was not from the insurers like Select or Blue Cross or any of those, because they have 24-hour, the ability to provide 24-hour authorization 7 days a week. The big pushback was from the Public Employees Health Plan, because they said, we're closed on the weekends. So if you require us to have staff there, we're going to, and they have the ability to do this, we're going to put a $5 million fiscal note on it. And so that's some of what was happening this time again, saying, and we're going to put a huge fiscal note on it. And they are a government entity, the Public Employees Health Plan, and so they can put whatever size of fiscal note on it that they want to. And so that was some of what was happening with this again. I'm sure that Representative, but she also introduced at the last part of the session, and so it would have a very hard time getting through the process. But this will come back again this year. We'll discuss it, and we'll see if we can move forward with different things that help with some of the prior authorization issues and problems. All right. I want to mention a bill from 2023. So Dr. Baca, when she and I met, and she asked me to present to the Ogden Surgical Medical Society, we talked about the invisible conditions. And I don't know if you're all aware of this. We did send information out on this at the end of the 2023 legislative session. But it is important that many of you physicians in this room and other healthcare providers in this room who provide care to patients who have what's considered an invisible condition, that you're aware of this. This was put in place for mainly for emergency medical services, because the argument was, and this was by, I didn't put his name either, it was Senator Jake Anderegg who was pushing this one, but sometimes when emergency medical services come to somebody's home to treat a patient, there's been a call. It's somebody who has autism or some other invisible condition. I have handouts, by the way. There's 100 handouts at the back that has more information on this for you. Jackie, one of my staff members, is back there. She can help or go back there and pick up that. The information on this is requiring healthcare providers to do certain things. So if you know that your patient has an invisible condition, and I'm just going to read what's on the form that DOPL created in conjunction with the Department of Health and Human Services. If they have any kind of communication impediment, post-traumatic stress disorder, blindness or visual impairment, autism spectrum disorder, Alzheimer's disease or dementia, hearing loss, drug allergy, epilepsy, diabetes, heart condition, traumatic brain injury. I don't know about the drug allergy. That's more to say, hey, emergency medical services, don't give them something. Schizophrenia, developmental disability, Down syndrome, or you can list an other. Then they have to be told about the fact that if they want, they can be on this invisible conditions list that the state will keep, an emergency medical services database, that they can pull up to say, oh, we're being called to this house. There's a patient here that has whatever condition, so let's not turn on the sirens when we get up to the house, or we're not going to be able to communicate with them, or something else. So DOPL should have provide information, it's probably on the DOPL website, to each healthcare professional in the state, or maybe they sent you an email. I don't know if they've even done this yet, but about the program and how to access educational materials, and that you need to make these materials available to patients. Now, I looked to see if the rule was in place. I didn't see a rule yet, so until a rule's in place, they won't enforce this particular bill, because they put rules in place to follow bills that are passed. But you know, we're going to push to say you just give your patient a reference to a DHHS website. They can go, they can look at the resources themselves. There's no reason why you should have to hand them information for emergency medical services. One, you don't even know if they're going to need emergency medical services. And two, it's an incredible burden on a clinic or a hospital or physician's office, a provider's office, to have to do some of this stuff. So you do have to educate your staff on it, but again, there's not enforcement happening right now, only because I don't see that a rule is in place. Until that rule's in place, they're not going to enforce. Now they might, if something happens, they might say, hey, are you aware of this? But this is something where you're going to have to complete a form. It will either be that the patient will bring it to you, or you will have to have a form in your office if you know they have one of these conditions to fill out for them to submit to the driver's license division. Driver's license division will also provide them with a decal for their license plate, and then also alert emergency medical services that this has been received. Let's see, some of the, and so I have handouts on this information at the back if you want to pick that up. And I think I still have 15 minutes, but I was told to leave time for questions and answers, so I think we're done. So happy to answer any questions if you have any. I know that sometimes legislation is extremely boring, so you may have no questions.
You made it fun. Thank you so much.
Thanks.
I'm wondering where you were talking about the methadone clinics now mandatorily reporting to the CSDB site so that we have access to that. Is there any hope ever that we're going to get information from the Hillfield or the VA or any of the federal? Because none of it's on the websites.
Yeah, so that's a good question and a discussion that's been had. The problem is, of course, we can't pass state legislation to require federal entities to do something. So that's going to have to come on a federal level, unfortunately.
Perhaps they should set up a pharmacy where the federal people fill their own prescriptions so the state people don't have to contend with their non-compliance with handing in information.
We've had multiple discussions about this when we've talked about the controlled substance database, so I absolutely feel your pain.
It makes it really tough, and they're integrating, I think there's 15 or 20 states now that you can get in through the CSDB. So at some point, they ought to just, bite the bullet like they did with marijuana and something.
Yeah, absolutely. Okay, yes?
To follow up on that same bill.
That's better.
I noticed in that bill, it talked about not just like methadone clinics, but any clinic that administers a medication, substance. And the obvious example that's coming to my mind is injectable.
Suboxone.
Well, not Suboxone. Suboxone's a prescription I typically send to the pharmacy. Right?
Yeah, that's true.
But we'll do injectable buprenorphine,
Yeah,
Sublocade.
that was the other one.
Would our clinic then have to report that also?
Yeah. According to this bill, yes. Now, rules aren't out yet, so we'll see how that's going to happen, what's that's going to mean. But I imagine so. And again, remember that was Representative Ray Ward, Dr. Ray Ward. But it is an issue knowing what a patient is on if you're going to prescribe to them. And so this has been a multi-year discussion, by the way. I told you I wasn't going to mention, and I'll get to you, Bill, I wasn't going to mention federal legislation, but I do want to mention one thing. You all know that the Federal Trade Commission passed final rules on non-competes. That's been an issue, at least for physicians in different areas over time. So they passed the final rule on non-competes just about a month ago, and it does not allow you, if you're in an independent practice, physician practice, to use non-competes. You cannot. Because you're for-profit. Now, if you're in a large system that's not for-profit, FTC cannot compel, does not have oversight over non-profit organizations. So just a little tidbit for you on a federal level. Bill?
Yeah, I was curious about the placental bill that you showed, and you introduced the idea of stem cells. I just became aware, and it should be an obstetrician up here asking this question. When I was in medical school in the 70s, that's the 1870s, the placentas were just thrown in the freezer, and I assumed they were thrown away. But I became aware recently that they use placental tissue for skin grafts. Mm-hmm. Is that considered a stem cell if you use placental tissue?
Bill, I don't know the answer to that. That's the one question you would ask me. I don't know the answer to that. The description, I do have a...
Well, I know there are services in the state now that will collect placental tissue to be used for various transplants, such as skin grafts and that type of thing. But
So
I didn't
here
think
it
of those
says,
as,
stem cell therapy does not include treatment or research using human cells or tissues that were derived from a fetus or embryo after abortion. It does not include, I'm not sure I have page 1. There's something else.
Okay.
But I don't have page 1 on that, so sorry, Bill. I don't know the answer to that.
all right, I'll discuss it later.
I can look it up for you, but not right now. I did want to mention too, one last thing. There were numerous, and this is specifically kind of more for the physicians, numerous scope bills. I'm not going to discuss them here because of the diversity of the room, but if you're interested in the scope bills that we fought or interacted with this year, please see me. So thank you for your attention. Appreciate it, and we'll continue to fight.
We do appreciate the really faithful service of Michelle McOmber. How long have you worked for the UMA now? 19 years. So we appreciate her long service. And again, if you are not part of the UMA and you live in Utah, you are missing a wonderful opportunity. And one of those opportunities comes every September when we have the House of Delegates.